राइट लोअर कॉर्नर में जो है ना वो फुल स्क्रीन का ऑप्शन है, उस पे क्लिक
Bhargav, at the lower screen, lower part of the screen on the right side, and as Madam said, the cup shape icon is there. That I think you can press it and it will be full screen.
Okay. Sorry.
You can just click it so that it is confirmed that it becomes the full screen.
Hello.
Bhargav, did you get that icon? On the
Which one?
lower down, right side.
I have done the cup sign. Then I got
then it is not seeing the full screen on my laptop, or I think must be there at others also.
Now it is a full slide view.
Then otherwise you can go for slideshow. In the top of the screen, there's an animation and slideshow.
If you, that is also another option, as Madam said. At the top, you can start from the left side, animation, and then slideshow.
Just after animation,
Try to search it with very calm mind. It's not difficult.
Now I can see it is a full slideshow.
I think somehow it is not on our screen. So
what you can do, Bhargav, you can do one thing. You can stop screen sharing.
Yeah, stop sharing and then start it. Then I think it will be in order.
Okay.
Yes. Now again share the screen, but with that, which is the full screen. With that screen you need to share.
Okay. Now?
Yes, now it is full screen.
Perfect.
Yes.
I think
and now you have a right and left arrow.
Now you can start, I think.
Yes. So now stop screen share again. And
I think let it be there.
It.
Let it be there. Don't disturb him.
Okay, then leave it.
My slide is not changing.
No.
Go to the left arrow. Left arrow.
Even now
here,
also.
No, and not on the keypad. You can do it on the keypad also. Left arrow છે ને?
હા ma'am, left arrow.
So એનાથી નથી થતું. Up or down arrow?
Up and down. You can go for down. Then you will get the next. It's not working.
Yes, stop scan. Sir, let me introduce first.
I think let us confirm, but suppose if it does not work, then it will be. So I think Bhargav, number one, you should be very calm. It's not difficult.
So one thing he can do, he can send it to a host.
Even host.
She will display and he will go on reading the things.
I think
facing difficulty.
I think every time, Nihal, we can request this presenter to send this PPT to the VIP person, host, I think, here.
Yeah, sure, sir. Bhargav, will you be able to do, or you can send the PPT to me?
I think now Bhargav is not probably, its net is not working probably now.
He left. He joined again.
Yeah.
Yes.
Bhargav, unmute yourself.
Unmute yourself.
Bhargav, you are muted. Unmute yourself. Yeah.
Yes. Now, same way, share your screen.
Now I can change my slides.
But there is no screen shared.
Yeah,
you need to
You're changing at your own
yes.
desktop.
No problem. You can do it. It is going to work.
No problem. Yes. Share your screen first.
And 5-10 minutes we are late. It does not make any difference. So don't worry.
Okay, sir. Can I now start it?
No,
I need your screen.
You can share.
Screen. નીચે શેર કન્ટેન્ટ લખેલું છે ને ત્યાં શેર કરો સ્ક્રીન. ગ્રીન કલર નું શેર કન્ટેન્ટ છે.
डाउनवर्ड्स
नहीं
जो नीचे छे पार्टिसिपेंट चैट
हाँ सर हाँ
પછી शेयर स्क्रीन ग्रीन कलर
हाँ वो किया है सर अभी
सब
माइक्रोसॉफ्ट पावर पॉइंट में एक्टिव अभी ऐसा आया है
okay now make it full screen slide show what you did it last time slide show
हाँ ओके
somehow
Can you see my slide?
no it has not become the full screen it is seen but not the full screen
I think you have to bear with this.
okay if it is not possible
even
then
now?
it's all right
Devalina, I have shared the PPT in our WhatsApp group. Can you please check and
in
share?
that case, we can do one thing. Like we can go ahead with the slideshow only. Like he can only share the PPT and then we can proceed. Like sometimes from that also we can do.
So do it.
Like just share the PPT only, not in full screen.
Yeah,
Okay.
but he has shared. He has
Now?
shared already PPT. Now can you?
Are you in full screen, Dr. Bhargav, from your end?
Now it is full.
No, don't do full screen.
Slideshow.
Just remove the full screen, doctor. Remove the full screen from your end.
हाँ sorry हाँ madam removed.
Yeah, and just go through like one by one. Can you please go through that? Like come to the second slide. Come to the second slide manually. Yeah. Can we go ahead like this?
okay no problem
Yeah. Okay, sir.
Okay, so I'm starting. And Devalina, you can start.
Ma'am, you can start from your end. I have started the recording, so we can proceed.
Okay.
You don't want to play the clarinet video?
No, ma'am. Today you can start from your end.
Okay. So good evening all, and I'm so much happy to go again with the e-Gurukul PG clinic, and this time the PG clinic case presentation is on central nervous system. We have the team AOP Gujarat, President Dr. Rakesh Desai sir, and the Secretary AOP Gujarat Dr. Kirit Sisodia sir there to continuously support us. Dr. Baldev Prajapati sir, who is the convener of this project and doesn't need any more introduction. Dr. Prashant Karya is a project coordinator in this AOP e-Gurukul. We have the PG clinic case presentation this time by Dr. Bhargav and his mentor, Dr. Mehul Gosai. He is an associate professor and HOD at present at the Government Medical College, Bhavnagar. Welcome, sir. Welcome, Bhargav, and all the best.
Okay.
We have our renowned experts, one from our own Gujarat and another one from the India level. So once again, we thank you, Dr. Kalpana Datta ma'am. Ma'am doesn't need actually any introduction, but still I am giving that she is a professor in pediatrics and director at Pediatric Center of Excellence in HIV care and at the Medical College, Kolkata. She was President-elect 2022 in West Bengal Academy of Pediatrics, and she is the President of Association of Pediatric Neurology, Bengal, from last 2015 to 2022. She is Chairperson-elect 2022 in Academy of Pediatric Neurology and Vice President in West Bengal Academy of Pediatrics. She is EB member as West Bengal Academy of Pediatrics and in 2017 and Neurology chapter in 19. She has other positions also, like is zone coordinator and many more. She is the subject expert committee SEC in CDSCO in 2017 to 2022. She has many more publications, more than 55 papers. She acted as PI and co-PI in many researchers, and she has many MD and DNB students under her. She is the author of textbook of pediatric neurology and PI textbook of pediatrics, pediatric hemato-oncology, and national technical guidelines on ART. So we welcome ma'am. Kalpana Datta ma'am.
Thank you. Thank you for nice introduction.
We also have
and one more whether in World Cup within a short time Madam will be contesting for the Central IP Executive Board member from the West Bengal. So,
Yes.
Madam, all for the grand victory for your Central IP election.
Thank you, sir. Thank you.
Yes, best wishes, ma'am.
Thank you.
We also have with us Dr. Nitish Vora. He is a director and senior consultant at the Pediatric Neurology and Epidemiologist at Royal Institute of Child Neurosciences, Ahmedabad. Sir is a great help in each and every cases whenever we get confused, and they are always there. He is a research investigator in 3 projects. He has pediatric epilepsy and EEG facilitator at UK, Europe, and India. More than 30 international publication and many more than 50 national talks invited. Author in the 4 books chapter. He is EB AOP and at AOP Neurology in 2018 to 2020, and again EB AOCN from 2016 to 18 and 20 to 22. His special interest in epilepsy, brain injury, autism, and he had the award of Gujarat Nu Gaurav on his name. He has the best academic poster in ICNC in 2018. So we welcome Nitish sir.
Thank you very much, Neil Ben. Thank you.
And with this, I'm welcoming Dr. Yogesh Parikh sir if he shower some blessings.
Thank you, madam. Actually, I am traveling, not driving, but in the car. So go ahead, and thank you, Mehul Bhai, for joining us after a long period. We are waiting for you since long. So thank you very much with your active participation.
Yeah.
Thank you, sir.
Thank you.
Thank you, Yogesh sir. So I'm handing over this platform to Dr. Baldev Prajapati sir. Sir, it's all yours.
Good evening, friends. First, I think Bhargav.
Also, good evening, sir.
Good evening. Don't worry, this is also part of training, right? And during this type of the presentations in the beginning, these type of the hurdles, issues can happen. And suppose it takes some more time, it does not make any difference. Don't worry. I will say in the every examination also, always I tell my student that when you are free and when you say, we will start the exam. So I think nothing is to worry. And so when you are, I would say, discussing the case, you should not have any anxiety. Just for the flow of the discussion, you know that it is a little bit different compared to our classroom discussion. Here, first Bhargav will share with us the history part. We listen, all of us. Then first the students, what are the questions, their queries, some comments, some clarifications, whatever they want. And then after making this history part clear, we can go for our thought process, summary, that what you want exactly, what type of hypothesis, what type of the issue is likely. And then the details of examination. Again, we'll come back with our positive findings on examination, that what is the likely disorder with the child. And then naturally, finally, Bhargav will share with this whatever specific investigations they have performed, giving the final diagnosis. Meanwhile, first always the student should speak, and without any hesitation, please participate. That is more important rather than just passive listening. Keep your video on. All the students on the screen, keep your video on. And with this, even we have the 2 experts. Suppose whenever something lacking or something is new, they are going to share with us, and at the end, probably in the whatever the case it is, will be more clear and probably more learning regarding particularly this topic. I think before we start, I request again all the students that those on the screen, keep your video on and even give your introduction so that we come to know that exactly to whom we are talking. Avni, I think you are the person to start it.
Yes, so we have Avni, we have Tushar,
Yeah.
and Ravi.
Okay.
So
at least
all
give
of
your
you, please
introduction.
introduce.
Avni, unmute yourself. You are muted.
Hello. Good evening,
Yeah.
sir. Sir,
Good
myself,
evening.
Dr. Avni Zinzala. I am senior resident at Certi Hospital, Bhavnagar.
Fine. Next, Dr. Tushar.
Hello everyone, good evening. I am Dr. Tushar, R2 from Civil Hospital, Nadiad.
Very good. And keep your video on. Don't disappear from the screen. And even speak very freely without any hesitation. Whatever the question comes to your mind. Right? And I think third person also they'll say. Yeah. Yesha?
Yes,
Is it-
Yesha is there.
is it-
Yesha, please introduce yourself.
Yesha,
Ravi is there.
Yesha unmute. Ravi is there. Who is Ravi? Please.
Hello.
Not see. Yes, Yesha. Can you make your video? Can you make your video on?
Minute.
Yeah.
Yes. Yes, you are audible also.
Now introduce yourself.
My name is
Yesha.
Yesha Prajapati. Hello. My name is Yesha Prajapati. I am third year resident, Government Medical College, Bhavnagar.
Okay. So Bhargav, Isha, Ravi, Tushar. Ravi is remaining silent and unseen. So Ravi, can you make your video on?
Sir, my name is Ravitaya, sir. I'm first year resident in Certi Hospital, Government Medical College, Bhavnagar.
I think first year resident is always you are at maximum freedom.
Yes, sir.
Right. Anything you can ask. So I think first I wanted to make it some have taken few minutes so that Bhargav can be free from the stress. Now Bhargav, I think you can start your history.
Sir, I am relieved from stress.
Yes, yes. Now you can start your
I am
history.
free from stress, sir.
Fine, that's good.
Okay, sir. Good evening, everyone. I am Dr. Bhargav, third year resident from Certi Hospital. I am present a clinical case over nervous system under mentorship of Dr. HOD sir of Paediatrics, Government Medical College, Bhavnagar. And now I am going to start my case. Introduction part of my case is the Monpur near Amreli, belonging to lower socioeconomic status, born out of non-consanguineous marriage on the 23rd July, with a complaint of not able to stand since 2 days and difficult to sit from lying position since 1 day and not able to lift hand since 1 day. Am I audible?
Yes, yes. I think before you go for the further slides, let us take even the first two complaints only. He said that 11 years old boy has presented with not able to stand since 2 days and difficulty to sit from lying down position since 1 day, and even not able to lift the hands, that is also since 1 day. Tushar, how will you take it? Try to analyze. Tushar?
Sir,
What I mean to say, I think before you go for the analysis, would you like to know further from Dr. Bhargav? Some
yes,
more
sir.
points, some more clarification, which will help you to think, please.
Yes, sir. I would like to know is it generalized or is it one side weakness or is it on all 4 limbs weakness?
I think Tushar, he has not mentioned the weakness.
Sorry.
Whatever the mother says, from that we'll have to start the story. Mother said that not able to stand since 2 days. Suppose if you take only the first complaint, what other questions, what other points you will ask to the mother, so that probably it will help you for further thought process. Suppose not able to stand since 2 days. Is it sufficient for you to think?
No, sir.
Anybody? Your Avni, you can take it? Avni, unmute yourself.
I would require a little bit more information regarding the details of
Yes.
the chief complaint, so that I can be clear in my mind that what could be going on with the patient that we are having right now.
Yes, what information?
Basically details regarding the chief complaint, as well as what was the scenario, from how it all started, what happened, whether it was gradual or whether it was sudden, whether there were any
Avni, what questions you will ask to the mother, or even you can ask to the Bhargav. Yeah.
Okay. So, sir, whether since the patient was not able to stand since 2 days, so whether there was any precipitating event like history of trauma or history of any injury before that, I would like to ask that. And since the patient was not able to sit from lying down position.
But Avni, I don't know the trauma and everything. Not able to stand, I will say it is possible due to the pain.
Yes, it could be possible. Yes, sir.
So the Avni, the point is, how will you try to differentiate? How directly will go for trauma or CNS problem? Is it quite possible that due to the pain, child is not able to stand?
Yes, sir.
So that's the point. So how will you ask all these points? That's the point.
Sir, whether there is any change in facial expression on touching, whether there is painful, whether there is a presence of any tenderness or pain on touching.
In the history, for always what we say, beginning of onset, duration, progress. So I think from this point of view, suppose mother complains of not able to stand, I don't know how it started. How they notice.
Yes, sir.
Whether child was in the school and something happened, or any child was sleeping and not able to stand, later on they noted, or child was suppose some sitting or doing something, homework, and then they notice. So what happened? That will give the idea that is it in how it started the onset. This is acute or this is hyperacute.
Yes, sir.
So that will give the idea. So how you will ask all these skills? That is very important. Bhargav, can you provide the information how the mother noticed not able to stand?
Sir, there is a history that mother has noticed that patient has been recurrently falling.
So that's the point.
2 times of falling episode while standing, and then he got difficulty in walking, and followed by that he suddenly stopped walking.
So Bhargav, this is the point I think which I hope that you might have taken in the origin, duration, progress. But that's the story that how it started. And many a times mother will directly complain of not able to stand. But if you ask them, was there any other issue or problem before not standing? Then what the Bhargav said will come out. That yes, in the school some problem, he was falling down, or even some difficulty in walking, and then probably not able to stand properly. So all these points should be asked. I think they must have done, but I wanted that before we go for further information, and then difficulty to sit from the lying down position. What does it indicate? The further progress. This gives the progress is within 1 day or 2 days. So that gives the idea that probably whatever the disease is of acute onset and progressing fast. Right, whatever the disorder, probably we don't know. That further we can go in the detail. But from these complaints, at least we can make up our mind that it is acute in onset and probably developing or progressing fast. Still probably more information will help you to further. Bhargav, can you go further for the next?
Sir. ODP he was apparently well 2 days before. Then he suddenly developed weakness of both lower limbs, presented as episodes of falling, 2 episodes of falling while walking, followed by patient being not able to stand without support and difficult to stand from sitting position. And on the next day onwards, he also developed weakness of upper limbs such that he cannot, his difficulty to sit from lying posture, but he can able to hold the objects. He was able to hold neck normally. He can do neck movements normally, and he is able to breathe normally. Weakness it is not in fluctuating type and not associated with any sensory symptoms or blunting of sensations. Bowel and bladder habits are normal, and he can able to close eyes normally.
Please, Bhargav, wait. I think he has provided good information. Now, who will take for further analysis? Dr. Ravi, can you take it? Or Dr. Deep is seen on the screen? We hope that you have seen the previous PPT. Yes, Tushar is there. I think again, this
Yes,
participants, you should keep your video on. You know, running away will not help for learning. Right? Don't be afraid of it. Never even have the shyness. Participate very actively. I think that is the first step to learn the medicine. Unless you speak something, nobody can. Even I'm sure that even all of us cannot learn. Right? I understand it happens initially, so don't worry. I am continuing to sensitize you. No problem. Now he has provided the information, Tushar. How will you interpret it? You know, he said apparently well. Bhargav, what do you mean by the apparently well? I think this is very common, our method of giving the history. But what do you mean by the apparently well?
Means by seeing or according to the mother, patient was well, but there might be some things that we don't know, that mother didn't appreciate.
You know, that's why there may be some hidden issues, minor some problems, which probably mother or parents may not give the importance, but which may be helpful for us for thought process. Suppose if you ask that, okay, not able to walk and fall and these 2 days, before that, he was absolutely all right. Was there any problem? Then probably mother may come out with these things. That not absolutely well, probably complaining some pain, or not even playing, which he was in the evening daily going to play. But since 4 or 5 days he was not going to play, or not eating properly, not sleeping properly. Or, you know, then all these issues will give you some idea that probably some problem started before even 2 days. And that will give you the idea. Suppose classically it happens in tuberculosis. In tuberculosis, they will complain of only 3-4 days. But when you say, no, sir, वो खाने का तो प्रॉब्लम ऐसा था, 15 दिन महीने से तो खाने का कम कर दिया था, वो स्कूल में भी जाने का मना करता था, थक जाता था. You know, then all the points start that probably disease process for, and कभी-कभी ऐसा लगता था कि बुखार भी है, थोड़ा सा गर्म लगता था. That means the fever started 15 days back. Then probably decrease appetite. But they will complain of the acute symptom. So the point is, in this type of some chronic illnesses or somewhere, if you ask before this apparently well time, they will come out with these issues. So always take it. I think very good, Bhargav, you have mentioned so that we could discuss this point. Then he has mentioned that these, if you can see the progress that developed the weakness, and therefore there was some 2 episodes of falling while walking, then not able to even stand without the support, that means with support, and then difficulty in standing. And so gradually, Tushar, how will you take it? What does it indicate? From this
Sir,
story, I think, yes, please take it.
Sir, probably maybe any muscular weakness is there, or can it can progress gradually?
From where it started? From where it started? History of fall and difficulty in walking or not walking. What does it indicate? Where the problem was?
It can be that like ataxia, like a central means.
Tushar, don't decide all these points from the beginning, right? This ataxia and all the things we don't know. It's very simple. Not able to walk, not able to, or finding difficulty in walking, standing. It indicates a problem with the lower limbs.
Yes.
Very
Yes.
simple. Very simple. And then there's that gradually then you describe that the next day weakness also progressed to both upper limbs also. So what I mean to say, if you simply think that started from the lower limbs, probably trunk also, then he's not able to getting up, that indicates the involvement of trunk, and now even the upper limb. So whatever the narration is given, if you try to interpret, started from these lower limbs, trunk and upper limb, then what does it indicate? What does it indicate? The methodology progress of the disease? Yes, Avni?
Ascending pattern.
Yeah.
Ascending paralysis.
So you know, narration story will be given by the parents, but how you are interpreting, that is very important. Mother will continue to speak in this way, but gradually I will interpret that yes, started from lower limb, trunk and upper limb. That means it is progressive, and progress is from lower limb to upper limb. That means, as Avni said, it is ascending. Am I right? So that's the point. Ultimately, we'll have to interpret the story. And further he has taken, and that also you can see that is in 2-3 days. So probably little bit fast progress, you can say. And further he has taken that at least he was able to hold the neck, that means neck muscles are not involved, respiratory muscles are not involved. That he has made the points clear. And further even the weakness is not fluctuating type, and somehow even you know that it is another point. Can you make it even ascending? Any other point, Avni? Would you like to make the comment regarding progress of the disease or regarding distribution?
As it started from lower limbs, so basically it is in ascending fashion, and then
Anything further? What I mean to say,
line.
Anatomical distribution, Avni. That means, is it symmetrical or asymmetrical?
Sir, it is symmetrical.
Yeah. So I think, you know, this is the thing. Probably undergraduate student, if it does not speak, I will say okay. But from the postgraduate, from us, it is expected. Our point is not just to listen the story. From the story, I will try to find out the points to understand it. That it looks like rather than pain, it is the weakness. You know, not able to walk can be the different reasons for pain also. Now, suppose patient of polymyositis, but that will be more of the pain. One can manage, but with difficulty. Here it's difficult. That means it's a neurological problem. It is ascending. It is fast progressive. Probably it is symmetrical. So try to derive all these points from the disease. And somehow, as he has mentioned very rightly, Bhargav has, I will say, intelligently mentioned that bladder and bowel not involved. And these have the story of neurological, that what it could be. That thought will come to your mind. And even he has mentioned close the eye. That means eyes are not involved. Bhargav, what was your idea to mention the bladder, bowel, eyes? Why you mentioned?
To rule out any other neurological impairment. Probably sometimes the weakness is associated with maybe due to transverse myelitis, in which bladder and bowel habits will be disturbed. There will be no continence. There will be incontinence in.
But suppose if it is, I will say, as you were telling, it's a suppose neuromotor problem. Still bladder bowel involvement can occur.
Autonomic involvement.
What I mean to say, it's a flaccid variety.
It is a flaccid variety.
Still, this bladder bowel involvement can occur. Anyway, I think this
also
point
if autonomic disturbances are present in any flaccid variety,
I think this point will take later on at appropriate time, not at present. Just I'm drawing your attention, and with the eyes also. Anyway, but I think it's mentioned. I think before we go further, let us take the help of the experts. Dr. Nitish and Dr. Kalpana, would you like to add something so that only one from these two slides, please, Dr. Nitish.
No, sir. Bhargav has done very good job. I think sensation, bladder bowel has been there. So basically, from any history and examination, we want to know whether it's acute, chronic, then pathology process, what's going on. And then from there, gradual history examination, we come to etiology, differential, and then come to diagnosis. So I think that's more of a collection. I think no altered sensorium would be something helpful as well, because some of the children
we
may
will
have.
come to.
Okay, next part. That's fine. So we are talking about the weakness, how it started, and any associated things with the weakness.
Yes, Madam, Dr. Kalpana.
Yeah, he has nicely explained the thing, but he has said the acute onset and the ascending, the progression. What he didn't mention about the precipitating factors. Whether there is any fever, any gastroenteritis, any RTI, any precipitating factors.
I think, Madam, yeah, he said that wait for some time. I think must be in the next slide.
Okay. That might be there. Okay, we should wait.
Okay, Bhargav, so even they also say that you've done the good presentation.
Yes,
nice. Okay, can you go for the next? Just from the two slides for the students, what I wanted that from the complaints, always try to define number one. That what is the chief complaint? When multiple complaints are there, try to find out the chief complaint. That will give you the focus. Then second, from the history, try to get how it onset, how it started. It's a acute, it's a subacute, it's a chronic, it's a hyperacute. If the person is fine and the next moment it becomes a very critical, that's a very hyperacute. Anaphylaxis is a hyperacute example. Sometimes hemorrhage can, even in the CNS, can present hyperacute. The person is talking and next moment there's some problem. So that is hyperacute. Acute, usually takes some days, a week or so. And subacute gradually, even a few weeks. And chronic will take still very long time, some months together. And that will give the idea regarding the different conditions to categorize that what are the varieties or problems. And then always, what apparently we say, try to find out that before these problems, was there anything? That is very, very important. And from the description, if you try to interpret, that will help you a lot for further thought process. And in any case, any system, always keep this type of the thing. In short, as the mother start to speak, your brain should be on. Your thought process should start. Immediately, you should start to analyze and try to derive some meaningful inference from the description. I would say that's the beauty of the history, which we'll have to do in every case, whatever the system it is. Okay, thank you. I think you can go further, Bhargav.
Further details are there is no anosmia, no blurring of vision, no double vision, no drooling, no drooping of eyelids, and no normal sieving and no drooling of saliva from the mouth, and no nasal regurgitation, no hoarseness of voice, no angle of mouth deviation, no feeding difficulty, no hearing impairment, no difficulty in doing tongue movements. There is no history of fever, headache, vomiting, myalgia, and no history that is suggestive of trauma, snake bite, insect bite, toxic intake, and no history of abdomen pain, girdle pain sensation, back and neck pains.
Avni, I think we'll have to explain why he has mentioned so many things. What was his idea? Or just, I will say...
Point mentioning that there is no anosmia, no double vision. It is to rule out whether there is any cranial nerve injury or not.
Okay,
To
fine.
exclude out that. And the second point suggesting of no history of fever, headache, and vomiting is to rule out whether there any whether we are suspecting any infective etiology or not, or whether there is involvement of CNS.
Madam, can you mute yourself, Dr. Kalpana, please? Madam, can you mute yourself, Dr. Kalpana? Dr. Kalpana, can you mute yourself? Anyway, continue.
So the first point was to exclude out the cranial nerve damage. And the second point, including
I think regarding nasal regurgitation and even the aspiration, which cranial nerve is going to be involved?
Palate 9, glossopharyngeal.
Okay, good. And hoarseness of voice?
A 10th vocal.
Vagus.
Very good. Very good. At least keep in mind, you are knowing it. And you know, in the exam also somebody may assess that whether you are aware of it or not. Very nice. Very good. Why the fever, headache, vomiting he has taken?
Sir, to rule out any like cerebral edema, infective or any other inflammatory causes leading to any cerebral edema. So to whether and myalgia, to rule out whether there is any.
I think how the snake bite is relevant in this case.
The neuroparalytic snake, the snake poisoning which leading to neuroparalytic attack.
Okay.
Cause for the weakness of the lower limb. So.
And pain in abdomen, neck pain, girdle pain. All the pains he has mentioned. Big
Trauma or any trauma-induced.
I think you can ask Bhargav that what is your idea. Always, you know, I'm sure that you are from the same department.
Yes, sir.
Always make the group and discuss among yourself.
Yes, sir.
And whenever your friend is speaking, always contradict that this is wrong. I think first reaction should be like that. Then there will be the good discussion. Bhargav, what was your idea regarding all these pains? What you want to convey?
Sir, regarding myalgia, I was suspecting a patient might be having acute onset myositis, viral myositis and everything.
But pain in abdomen?
Pain abdomen, it might be due to acute intermittent porphyria, which can sometimes present as weakness, general reflexive palsy. So I have asked regarding abdomen pain, and regarding neck pain, I was suspecting patient might be.
Bhargav, my question, did you come across any patient of this porphyria?
No, but
okay, now further. And that too with a neurological, and that too of 2 days duration. Why I'm coming to this point, in the exam if you mention, it indicates that you are biased. I think suppose somebody is asking, then you should be knowing. But I think when I'm presenting, in that too in the 2 days weakness, unless there is some past episodes, you can. So again, what I want, that relevant to the story of the patient. You know, so many things can be given in the standard textbooks. Every point may not be relevant to my particular case. I think snake bite is relevant to some extent. Reason is, you know, both can present acutely. And somehow it is not common in Gujarat, fortunately, but some of the states, yes. That even the child, or particularly more common in adults, that sleeping in the farm during the night time, and in the next day morning, person is found with this type of the flaccid paralysis, brought to the hospital, and that's snake bite story. So I think that is possible, right? Anyway, but it's not totally wrong even, I will say. It's a good point. Okay, further. Then we'll go to the experts with your full information. Bhargav, can you go ahead?
Okay. No history suggestive of altered sensorium or behavioral abnormality.
I think before that some past history was there in the slide.
No, sir. This is the slide. This is continuation of my
okay.
ODPI.
Fine.
No history that is suggestive of altered sensorium or behavioral abnormalities, no seizures, no recent vaccination in last 1 month, no any flushing and sweating, and no honey and canned food substance ingestion.
I think now I should go to the Asia. Isha, are you there? Please make your video on. Isha.
Yes, sir, I'm here.
Yeah, keep your
But my
video
video
on.
is sir, it is disabled.
Okay, okay. I think, can you interact that, he has mentioned recent vaccination. How it is relevant in this case?
Sir, post-vaccination acute fatigue paralysis.
Can you give some examples? Which vaccine?
DPT boosters, he might have taken DPT booster for that.
The DPT is known to cause this type of the problem?
Yes.
Yes, sir.
DT, hepatitis B, influenza, meningococcal vaccine type C can cause,
This type of
and rabies, anti-rabies serum, anti-rabies vaccine. These all can cause weakness.
What are the common adverse effects of DPT?
Excessive cry, persistent cry,
fever,
and and the pain that inconsolable.
Avni will help you.
It will.
I think he's trying to recollect regarding some muscle tone adverse effect of the DPT. Am I right, Bhargav?
Sir. That will be the
I can make out
weakness.
from thought process. What do you call it? What do you call it?
I forgot the name. It will be starting with.
So I think some other person should remind him. Isha, can you?
SSP.
No,
Not
we are
SSP,
talking.
HHP.
We are talking regarding this DPT adverse effect, and he is trying to recollecting some name which starts with the hypotonia. What do you call it?
So,
have you heard of HHE?
Yeah. Avni? Anybody?
Hypotonic hyporesponsive shock.
Not shock.
No, sorry, syncope. Episode.
Not syncope.
Episode.
It's an episode. And here you know what happens. It is a hypotonia, hyporeflexia, and that is just episode. I think please don't mix up like this the picture. And therefore the common vaccine, I think suppose if you are thinking for the GPS, and with that reference, if you want to ask the history of the vaccination, which vaccines are common, known, that even following that vaccination, you may develop the GPS. As I am directly asking the question so that you can understand.
Post-rabies, post-influenza.
I think rabies, yes.
Rabies and influenza.
Influenza, yes.
meningococcal.
Not meningococcal. I don't think so. Later on, I think if something, Nitish will correct it. Most common what they describe, influenza, yes, rabies can cause, and that too probably not this modern anti-rabies vaccine.
Actually, sir, meningococcal type C conjugated registrated there.
Okay. And hepatitis B,
that's
I
why
think
he is telling.
hepatitis B is known. Hepatitis B is known for this type of problem. So, whenever you mention the negative points, somebody is going to ask you. So, you should be prepared that which vaccines. Right. Similarly, I think you have asked no seizures. What is the idea of seizures?
Towards palsy, transient postictal weakness.
How the Todd's palsy will present, Bhargav?
After any convulsion episode, there will be a transient generalized weakness.
What is the duration? What is the duration?
24 to 48 hours.
Yeah, right. So I think again, okay, you have to mention it's all right, but always what I mean to say, as far as possible, very relevant point, not everything given in the standard textbook. Okay, flushing and sweating, what actually, anybody? Because I want to involve every person. Tushar, can you take it? Why is mentioned flushing and sweating absent? What he wants to convey? I think, let me give the idea. You know, here we are not just to finish the case. Case is just example. From where that we want to learn many things. Any patient, any condition, suppose it's complaining with some this type of the CNS or some issue, but flushing and sweating. And even sometimes suppose there may be hypertension transient. If you measure the hypertension is there may be some tachycardia, there is some sweating, there is flushing. Only then what does it indicate? What I mean to say?
Involvement of autonomic nervous system.
That's right. That's right.
Autonomic.
You know, it is not written the autonomic nervous system disturbances any patient, but when you are having these findings, give the thought. Whatever the condition it is, that condition is going to be diagnosed later on. But that gives the idea that this patient is having autonomic nervous system disturbances. So just if I find the flushing and the hypertension in the episodic manner, what it could be? Flushing and hypertension. Somebody has previously recorded hypertension. When I came to me, blood pressure was normal. But then again came to me with hypertension and even the flushing. And even with that, with this episode, headache is also there. With the hypertension, what it could be. And it is going on since long. Anybody? You know, here it gives the idea. Let me go give you some clues or hints. That means hypertension is intermittent. In between somebody has noted, that means it is episodic. Flushing or the sweating probably is also episodic. And that means it is again involvement of the autonomous nervous system, particularly sympathetic nervous system, and which is episodic. Then which condition can present in this way? Not so common, but if you have probably, if you have idea, you can catch sometime. And it is the endocrinal problem. Let me give you the idea. It is not the presence at the CNS manifestations. Basically, the problem is the endocrine.
Hyperthyroidism.
Hyperthyroidism.
Something near kidneys.
Yeah. And then another consultant has advised some urine examination.
Cushing's disease.
The detection of some substance in the urine. And what it could be. I want the answer.
Pheochromocytoma.
Yeah. I wanted the answer from the students only. And I think that's the thing, any teacher, the students are knowing. I will have to sensitize. I will have to use some electrodes to sensitize so that it comes out. But I am sure that what actually was my idea, give the thoughts that what it can be. We do not know that which patient is going to come with which condition. But if you have thoughts, if you have ideas, then I'm sure that even the rarest condition in the Nelson, which I mentioned, you are going to get it. Right? So that was my just idea to sensitize you to that. Keep the horizons wide for the thought process. Then probably we can think many things. I think before we go further, let us take the help of both the experts. Dr. Nitish and Madam, whatever you would like to add, please. Dr. Nitish, can you take it?
Yeah, sure, sir. So now again, he's speaking very nicely. It's good learning for everyone. So I think all the differentials should be there, but I think appropriate differential. So like, as you said, Todd paralysis, definitely possible. It's acute, but it won't show ascending weakness or so I mean, I'm not saying So if you're thinking of causes of weakness, yes, seizures, post-ictal is possibility. But here, you know, the clear history, there's ascending weakness over next 2 days. So perhaps you can avoid those differentials. So to have a wider thought is very essential, but also don't include unnecessarily all the differentials. Porphyria will be there. Yes, I agree. Even a stroke, it can be there. Some infective pathology, so like say transosmolysis, or even some kind of myelitis can cause this kind of weakness. So those differentials are fine. But yeah, I think you need to keep your differentials wide open. And as sir said, whether you reach the diagnosis or finish the case is not important. Your thought process, your approach, that's more important.
Madam, anything from yours? I think, you know, Dr. Nitish has mentioned very, very right point that once you decide that it is the ascending, is progressive, I think that type of presentation is not going to be with the thoughts. So that's the point. I would say a very good point, how you can even explain to the person or even to yourself when you are thinking. Yes, madam, please.
Yeah, he has written the right point. That is, no history of seizure. The explanation was not right, actually. Third person should not be the DD. But seizure is a very important point you must know, because the central nervous system is involved with the peripheral nervous system or not. Or sometimes, like a non-polio enterovirus can have a convulsion. Hypoxia can cause convulsion. Even the GB polio, we know there's sometimes convulsion, though it is eradicated in our country. But the seizure is a good point to be included in the history. But explanation should not be the thoughts person.
Yeah. Thank you, madam.
Okay.
Bhargav, you can go ahead. I think your presentation really you have prepared very nice. And your colleagues are helping you. You can go ahead.
Past history, there is no any admission in the past, no history of such similar illnesses in the past, and no swelling over the neck, throat pain, fever since 1 month. No any cold, cough, and diarrhea, difficulty in breathing since 1 month. No any surgical history and no any blood transfusion, not taking any regular medication.
Okay. Again, just to remind you that negative points are something, whatever you mention, that should be relevant to your problems which you are analyzing. Second, nearby differentials. And third, probably expected complications. That you can say. Suppose if you are thinking the GPS, you mention suppose not respiratory involvement or hypoxia or something. I think it's a relevant point because that is expected complication, right? Or some nearby differentials you can. So that's I will say, and even regarding some etiology, what you mentioned, vaccines, yes. I think Avni Bhai has mentioned cough, cold, and diarrhea in this patient.
It might be common for diarrhea. Campylobacter jejuni is common in India. Then it can progress to Guillain-Barré syndrome. That can cause plaxiplasty.
So you know this is in yes, madam, you can take it, please.
Yeah, even the enteroviral infections, non-polio enterovirus is more common than, because polio is already eradicated. So we are concerned about the non-polio enterovirus that can present with the diarrhea. Yeah. So this is the explanation for taking the history of diarrhea.
So I think good points you have mentioned. Please go ahead.
Birth history is uneventful. Antenatal history outcome is full-term normal vaginal delivery, and birth weight is not known, no any NSU admission, and fed exclusive breastfed for 5 months and continued breastfeeding till 1.5 years. There is nothing significant and related to our present illness.
I think Bhargav, here only one question. Suppose some student is doing good in the exam. Some examiner maybe, I would say, tempted to ask, when the student like you doing the good performance. In the birth history, after the birth, the baby is found with a quadriparesis. It's a lower motor neuron type of problem. There was no history of significant birth asphyxia. And it was brief presentation. How it happened? Can you explain?
Quadriplegia.
Yeah.
Birth trauma to the cervical, spinal trauma.
How it happens?
Daily forceps delivery.
Not, it was the I will say bridge presentation, and usually they don't go for the forceps in this type of the thing. But at least you have mentioned, that's good. Avni, any comment?
While breech delivery, while pulling the baby out of the vagina, so that might have lead to any trauma, which could have been the cause for the neuroparalysis, muscle
Yeah,
paralysis.
it is called the traction injury.
Traction injury, traction pull method.
In breach, it happens so.
Mhm.
And many a times even these type of the injuries that spinal cord, when it's a traction injury, and in that case this type of the quadriparesis you may get it. So by chance, as I said, commonly we will not ask this type of question, but occasionally you may come across, it may happen so, or somebody would like to know whether the student is aware regarding this aspect or not. Okay, I think may not be relevant to our case, but suppose in the birth history and this type of presentation, if you want to know some good student, the examiner may ask, okay, I think here in this patient, birth history is not important. Not relevant, I will say, everything is fine, right?
Yes, sir.
Okay.
Vaccination history. Patient has been vaccinated till 5 years of age as per the national immunization schedule according to mother, confirmed by age and site of administration, but no any documentation was available. And BCG scar has been present, and developmental history appropriate for it, but patient doesn't go to the school and perform all activities normally.
Okay.
There is no any chronic illnesses running in the family, no any contact with TB, epilepsy, hypertension, congenital heart disease and diabetes, and no any stroke-like illnesses in the family.
Bhargav, go ahead.
Nutritional history, my patient is having a calorie deficit of 390 and protein deficit of 5 gram as per 24-hour dietary recall method, and belongs to lower socioeconomic status as per modified Kupuswamy scale.
Okay.
And the cohorts at hospital, patient had gradually developed hoarseness of voice, pooling of secretions, breathing difficulty on fourth day of admission, and patient has to be intubated and done plasmapheresis cycles, and tracheostomy has been done, and chest physiotherapy, general physiotherapy has been given, and at present patient improved, and he was weaned off from tracheostomy and removed tracheostomy tube, and at present taking with O2 with nasal prong. Patient was kept for 45 days on a ventilator.
Bhargav, I think it should be the last slide.
Uh,
It should be the last slide, but no problem. I think now you can go ahead. You can stop sharing. I think we'll not interfere, just to stop sharing. We'll continue this way. But what is my point? That suppose history is over. Forget regarding the last slide of progress in the war. Before that, the history part we have discussed, I think, at length. Now from the history, what will be your summary or hypothesis? Please, from the student, I want to remind you, nowadays in DNB and even in the MD examination, at 3 junctures, they are going to ask you the summary. Number 1, after the history. Number 2, after the examination. And number 3 at the last. With even these suppose some investigations, or even some investigations nowadays even examiner brings with him and he may show. So the point is, I think you should have a clear ideas. Now from the history, in the summary, don't repeat the same things what Bhargav had mentioned. Right? I think that already we have discussed, analyzed at length. Go for its interpretation, its inference, and try to derive that what type of the problem is likely with the patient. That is called the hypothesis. I'm just giving the idea, and do this exercise daily in the rounds so that you can do much better in performance in the exam. Who will do? I want the voluntary participation. Either the Avni, Tushar, Yesha, and I think one person more was Dr. Deep was there. So I want some voluntary participation at raising the finger. Gradually, I am learning as a teacher that I should not force a person to speak, but let them come out by their own. I will wait for some time, I don't mind, but I want the voluntary participation. Great. Yes, Avni, that's good. I think you can go for your summary as I guided, do in this fashion.
Okay. Sir, from starting from the chief complaint till the history given by Bhargav, I would like to say that there is a weakness in ascending pattern, symmetrical involvement with no sensory involvement, no autonomic nervous system involvement, and pure, mainly motor involvement without any cranial nerve paralysis.
What does it indicate? Always, if I remind you the CNS case, try to think in this way, that what is the anatomy? Which part is affected? Try to derive from even the history. I think examination will be more clear. But from history also you can try to derive. Number one. Second, Avni, second, try to think that what type of the pathology it is. Suppose it is congenital or acquired. Is it traumatic, non-traumatic, inflammatory, infective, non-infective, space-occupying lesion, degenerative, right? Autoimmune, neurometabolic, so many groups are there. So try to derive your whatever you have said, even may not be right. On examination may get changed. No problem. But from the history, what you are considering, and then if possible, likely etiology. Suppose if you say infection, that really bacterial or tuberculosis or fungal or something, right? So keep, even what I mean to say, keep this your goal that you want to put in this fashion, and that attempt itself is sufficient. So Avni, you can do it again.
Okay, sir. Weakness, mainly motor predominant involvement, non-traumatic and non-infective could be the origin, and without any involvement of sensory and autonomic nervous system, mainly predominant motor involvement in ascending pattern and symmetrical paralysis.
Okay, very good. At least good attempt, I will appreciate. Anybody, one more person wants to do? Because, you know, first person gives some ideas. Second person can do even much better because he has an opportunity to modify it. Who will do? Tushar, Yesha, anybody? Please do it. Always, on the contrary, your readiness to do is more than sufficient. Never hesitate to speak. Yes,
Yes,
Tushar,
sir.
please.
For the history given by Dr. Bhargav, it looks like non-traumatic and non-autonomic and acquired sudden onset and non-infective type of etiology, could be autoimmune and not congenital also.
Okay. Now, whatever you said, put in one sentence. Your points are valid. Try to prepare one sentence. Avni is waiting. That's good. Okay, Avni, you can go further. You want to modify your own statement? That's good.
Sir, acquired non-infective, non-traumatic, ascending motor paralysis without and secondary to any non-infective etiology and non-degenerative and without any developmental delay.
Fine. As I said, always try to put it anatomy, pathology, likely etiology. And second thing, always use the multiple adjectives. Use the multiple adjectives. As a acute, subacute, chronic, progressive, non-progressive, rapidly progressive, slowly progressive, right? That will give the, I will say, clarity of the group of the disorder. And the disorder can be anything, no problem. Right. I think here simply we can say that 11 years old boy has presented the ascending type of this weakness or paresis from the lower limbs to trunk to the upper limbs without involvement of bladder and bowel or even the cranial nerves, and this progress is symmetrical without the fever. So it seems to be peripheral nervous system involvement, the absence of seizures and other things. And that too looks lower motor neuron type of lesion. And it looks like more of the flaccid, and which is progressive in the few days. Then probably it should be non-infective, immune-mediated disorder, rather than this infective like poliomyelitis. And really, if it is so, then the Guillain-Barré syndrome like manifestations are common with this type of story. And I'm sure that which the anatomy you said periphery, pathology if you are suspecting probably autoimmune or the immunological disorder, etiology likely you are telling that with this other story snake bite is not there, porphyria and everything we have excluded, polio remains nearby, but with the symmetrical and asymmetrical we can differentiate, and now the polio is at the bottom, and this is more common. Therefore, if you are whatever you are considering, it is quite convincing and most of the people will accept it. So I think that's the thing. I think before we go further, Dr. Nitisha, word from you and from Madam, then we'll go for the examination.
Sir, as Sir said, very precisely, concisely explained by Sir. And I think that's the purpose. Sometimes you know the diagnosis, but your summary, which can satisfy the other person, even yourself, and then you can build the further case on that basis. So anatomy has to be there. Think for pathology, as Sir said, and then etiology wherever possible. And that thought process should be very clear, and ask differentials accordingly and keep adding the information as required. And summary is the key. I totally agree, Sir.
Madam, anything from you, Dr. Kalpana?
No, sir, it's complete, but I think with complications to be added and any other illness is there in the pre-existing illness like malnutrition or any other thing that should be also included in the
Absolutely
diagnosis.
Absolutely. What Madam said is right. That also we have to take into consideration, because I know every our patient is having some other comorbidity. That is the form of the malnutrition or some other issues. So that's a very valid point that always we'll have to keep in mind.
Yeah.
Thank
if
you very
the
much.
diagnosis will be complete, then only the management will be correct.
Yeah, absolutely. Otherwise, you'll be missing the vitamin A to give in a patient of some neurological problem. Absolutely, madam. Thank you very much. I think now you can go for the examination. We have about 40-45 minutes and we want to utilize it. I think, always it is said that give the more time in the history analysis. Though it is said, Bhargav, nowadays, I think even the MD and probably the DM certainly, they will ask in this way that before examination, what you are expecting that these findings should be there in the patient. And I think that you should be able to answer. That now, having this type of the history and your analysis, that is said as expecting positive findings. And suppose in some patient it is deviating, then I will say my thought process is deviating, my diagnosis is deviating. So that should be the very focused examination, what the people say. So now with that idea, Bhargav, you can go for further your examination findings, please.
Uh, 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 coming to general examination, after taking verbal consent, patient is exposed, uh, full body exposed under adequate light, and patient is conscious, coherent, cooperative. Temperature is normal and pulse rate is 98 per minute. Regular rhythm, normal volume, no radial and radiofemoral delay, and BP is around 100 by 72 mmHg. In supine position, and SpO2 is maintaining SpO2 to 98% on room air, and respiratory rate is within normal 18 per minute. And coming to anthropometry, patient is
hello, can I interrupt?
Yes, madam, please.
Yeah, actually, we started examination, but on the history basis, what do you think? It is a GB ascending paralysis. So, what are the duties of ascending paralysis should be done? Like you have missed few history, like a dog bite is very important. One of the dog bite history should be taken, and the traveling history for the tick paralysis.
Yeah, that is also.
There are 4 DDs for ascending, like GBS, it may be varicose zoster, tick paralysis, or rabies. So when you're thinking of ascending paralysis, these things should be kept in mind and should be asked in the history that you have not mentioned in your history.
Certainly, madam. I think very valid point. Please keep in mind.
Now we can go.
Bhargav, you can go ahead from the point where you were there.
Yeah. Coming to the anthropometry, my patient fits into the less than third centile underweight according to IFE growth charts. Coming to the other points in general examination, there is no peculiar cyanosis, lymphadenopathy, and no any neurocutaneous markers are seen, and patient's skull, spine, and genitalia appears normal. No any spinal tenderness elicited. Coming to a general specific system examination, CNS examination, my patient's higher mental functions were normal, and his GC score is E4, V5, M6, and coming to motor examination, he is having no abnormal posturing. His bulk appears normal, and I have observed hypotonia in all 4 limbs. And coming to the power examination, there is a weakness of the shoulder, that is 2. But both shoulders have power 2, and both elbows shows power 2, and wrist show power 1, and his hand grip is weak. And coming to lower limb examination, there is a completely loss of power in both hip and knee, and ankle joint showed 1, and toe grip showed there is no any toe grip. And coming to the reflexes, all deep reflexes are absent, and superficial reflexes like conjunctival, corneal, and Georgia are present, but patient's plantar is unequivocal. Patient's sensations, normal sensations, can perceive normal sensations like pain, temperature, touch, and vibrations, but he proprioception cannot be elicited as he cannot move his limbs normally. And there is no nystagmus, and gait and coordination cannot be examined, and no signs of meningism, necrosis, any autonomic instability like sweating, temperature instability, flushing, tachycardia, palmar-edema, and salivation. Coming to cranial nerve examination, almost all cranial nerve examinations were found to be normal. And other system examination is essentially normal, like respiratory, serious, and elementary system. Coming to last diagnosis part.
No, you can just stop sharing. I think you can go to previous slide. Bas, fine. Any comment from the other students first? The general examination, then the CNS. First, general examination. Any point which you would like to ask Bhargav? Anybody? No point. I think to avoid this background noises, can you, those who are not speaking, can you mute yourself? So that I think there's, okay. Yasha, anything from you? General examination. Would you like to ask something to Bhargav? Probably which
More of
you
proximal
may not be happy, or if you in general examination before the CNS, then you will come to the CNS. Anything in general examination? Or fine, you are happy. Bhargav, if I ask you which important aspect is missing in the general examination, you can just give the thought. Try to find out yourself. And Tushar will help
Immunization
you.
history.
Yes, Tushar, what did you say?
Immunization history.
I think immunization you mentioned. In the history, already it was mentioned. On examination, I'm asking. On general examination, what he had mentioned, one important, I will say, point which they expected in any patient. Yes, Avni?
So regarding the position of the patient, whether how the patient was sitting, whether lying down, whether there was any.
The term is called decubitus. Decubitus.
Decubitus. Okay. It is a very important point which I want, Bhargav, and to all the students. Growth chart has to be there.
Sir, I have mentioned.
Mentioning is not sufficient, Bhargav. Bhargav, mentioning not sufficient.
Okay.
Growth chart should be there and plotted in any patient, any system. In pediatrics now, on the contrary, now the people say that there should be the very important 3 points in the passport of the child. And which are the 3 points? It has to be there in the passport of the child. One is the growth chart. Growth chart has to be there. Second, immunization. Immunization record has to be there in your history, in your record. And third,
development.
These are the unique points, and it provides lot many information regarding any system. So in the country exam, I will say the growth chart you will have to carry with you. You cannot ask or you cannot reply that because the center has not provided. They may not provide if they don't have, or they may not have all the growth chart. Candidate should go with all the growth charts. In the kit now, it should be there. And in the exam, it should be plotted. Whatever the system, nervous system, nutrition, elementary or anything. This very important point. Second, I think I'm not sure. Did you mention the fundus examination?
Yes, sir.
Sir.
Okay.
Mentioned in fundus.
Fine. If you have mentioned, that's good. This is also another point which always you should not miss, right? Because it is commonly missed in the exam. Now coming to the point, I think in general examination, is there any positive finding?
No.
Not much, right? That in the CNS, I think I request Dr. Nitish and Dr. Kalpana to focus the CNS examination findings, so that I think we can have the exact interpretation. Yes, madam, you can take it, please.
Yeah, actually, I wanted to ask the Bhargava the relevant general examination, which is relevant to your case.
Yeah.
Just mention what are the relevant general examination, which must be mentioned. So you have to look for that parts of the general examination relevant to your case. What are those? What are the abnormalities you expect from the general examination? Or what are the findings you may expect from the general examination? Like one is a temperature. One is the arrhythmia. It's an autonomous nervous system, BP. And respiratory rate is very important. The respiratory rate pattern, and you haven't mentioned the pattern also. Rate also, pattern also. Because there may be respiratory distress. And as you said, there's a distress and you have intubated a patient, and I think you have shown the slide, no? You have intubated the patient.
Yeah, even with this information, what Madam asked with the reference to that, Suppose if you are monitoring such patient for the respiratory involvement,
Yes, very important.
how will you monitor?
Respiratory muscle palsy can occur.
Bhargav, sorry, how will you monitor?
Sir,
You know, suppose on admission, there is no respiratory problem, but you know that at any time it can. And therefore, monitoring is very important. So how will you monitor the involvement of respiratory system, respiratory problem in a case of Guillain-Barré syndrome? Suppose direct question if somebody asks, how will you do? Yes, Avni?
Sir, there will be a lag in the breathing, but it will be more prominently respiratory lag as well as involvement of the intercostal muscle. So
Okay.
abdominal breathing, most probably.
Right. That's why madam asked regarding the type of respiration, right? Respiratory count. One more
Single
point.
breath count.
Suppose
Single
if
breath
I,
count.
yeah, that's good. Single breath count. Now, Avni, what is the single breath count? What is that?
Sir,
How will you test it?
Sir, I will ask the patient to speak, whichever the language he or she is able to speak, I'll ask to speak continuously in single breath. For example, 1, 2, 3, 4, 5. Unless he is ready to take the next breath, I'll ask the patient to continuously count.
Before anything, you should ask, because you are doing the specific testing. So before counting anything else,
Take small inspiration.
To take the deep breath.
Deep breathe.
And after taking the deep breath, in the one particular breath, person or child should count. And what normal person can do? Yourself or myself, what we can do? Up to what? Normally, that means.
Sir, 25 to 30 seconds.
I think, then
30.
I think then some exercise is required.
Right, sir.
Then some exercise is required. I think for interpretation, okay, that when will you say that the muscles are involved? Only that you can answer. What is the cutoff point for that? Single breath
20
count.
seconds. 20.
15.
Okay.
Less than 15.
Okay. And I think this is going to be there anywhere. Somebody say 15, somebody say 20, but okay, I think 15 to 20. I think maybe variable according to age of the child in our patients, but the point is you should have the idea. Or simply suppose is such patient, and you know this test why I'm asking, single breath count is given the dearly importance for the respiratory involvement in such patients. It's a good test before you go for any sophisticated investigation. So I think it was a good point, madam reminded. And please, somebody is definitely going to ask in the exam, and at least try to perform in your daily practice in such patient. And you know, that will give you the idea. Suppose the child was able to do up to 30 and now only 20, probably to give you the idea that this patient is going for this muscle involvement. That's the point which we should do. Madam, you can take it further. Sorry, please.
Okay. Yeah, so general examination, that's points to be kept in mind while dealing with the particular case. What are the general survey I could get some help for the diagnosis. Okay. Now go for the examination of nervous system. Again, the higher functions, the consciousness level, that may be altered due to the hypoxia also. So it's very important to know the conscious level and orientations on the child.
I think what we are asking, you have asked the seizure, whether seizures can develop in a case of GBS? Because we discussed that it's a peripheral nervous system problem. Avni, what is your idea? Tushar, any point?
Yes,
seizures is...
Yes, sir.
One point, madam said hypoxemia, but suppose directly involvement of CNS and seizures. Can it occur in GBS? I think these questions will come when the good scoring is there, like this team. Bhargav and Avni and Tushar and all these students, I will say they are doing really very well. Then these questions will come. Then let us ask to the experts, because this we'll have to learn from them. Dr. Nitish, can you just take this point of whether the seizures can occur and cranial nerves and this point? I'm sure that it will be useful to us.
Yeah, so if this is ascending GBS, depends on the pathology. So hypoxia very well said. Even the toxins, so like enterovirus and other viral infection can cause this. Hypertension itself hypertension can cause seizures. And if that's more worsening, if you have brainstem involvement, that can also cause seizures. So I think depends how different kind of stage you can have seizures for different reasons in GBS.
So very well point that even it's a peripheral nervous system problem, but certain varieties, even CNS
Brainstem
involvement is
and
also
like
known, and that to brainstem. I think that's a point which we can remember. Anything from you, madam, regarding this point? Okay. So keep in mind, when there was seizure, I said that at appropriate point we'll discuss. So this was the point that you can keep in mind. Suppose if you have mentioned just seizures and in the exam somebody is asking, if you come with this point, that the examiner will appreciate. That's not routinely, but I think for keeping in mind, is there a variant of this? And suppose cranial nerves are involvement, then what do we call it? Yes or no?
Miller-Fisher variant.
So I think let us learn from madam. Dr. Kalpana, can you take it? Miller-Fisher, I think it may be something new for general pediatrician like me.
Sir, there are varieties of, am I audible?
Yes, you are audible.
Okay. There are varieties of GBS, types of GBS, rather we say, like acute inflammatory demyelinating polyradiculopathy, that is the AIDP. Then it may be Aman type or Amsan type, means acute motor external neuropathy, acute motor sensory external neuropathy. And then the regional variant, that is called Miller-Fisher type. And then acute sensory neuropathy, and sometimes there may be an overlap syndrome also there. But in case of Miller-Fisher, it is we say areflexia, ataxia, and ophthalmoplegia. It's a rare disorder. Hello? It is a rare disorder. Rapidly evolving areflexia, ataxia, and ophthalmoplegia. Sensory loss is very unusual, but proprioception may be impaired. And it is there may be a demyelination. If you go for the investigation, can see in the 3rd and 6th cranial. And this particular type variety, we can have a urinary incontinence, which is about 20%. And of course, a transient variety. Others we know it is a 5 to 10% in GPs.
I think
different types.
Yes, I think from the CNS point of view, Nitish, can you take it that what are the positive findings are there, then for that interpretation, and then localizing anatomy and further, I think later on we'll go for a further discussion, whatever they have prepared, because I will have to keep in mind timing also.
Sure, of course. So CNS examination, what he has said is higher mental function, GCS is normal. He has no abdominal posturing, but I think decubitus is very important in part of general examination as well. And bulk is normal because if it's acute stage, we are expecting bulk to be normal. But if it's a long-term, you may have muscle loss as well. Is hypotonia in all 4 limbs, but with that, no abdominal posturing is bit contradictory. So if there is hypotonia, I would expect limbs to be floppy. And you will see kind of external rotated legs, etc. Now, if you come to the power, so it's upper limb, lower limb. So basically, you are saying this is more of distal than proximal weakness. It's symmetrical, and power 1 distally, power 2 proximally. And that makes sense. It's a level of the weakness, what your power is. Can you go to next slide, please? This is upper limb. So lower limb, basically there is even no flickering and perhaps some flickering at the ankle joint. So basically there's a total weakness of lower limb and significant weakness of upper limb as well, which is symmetrical. Can you go again to the next slide, please? So all dependent reflexes are absent. So with your history of ascending weakness, hypotonia, floppy, and power very low 2 or whatever, your dependent reflexes are also absent. So that's a peripheral nerves involvement. It's more likely, or something in the spine as well. You're also taken the superficial reflexes, which is more of a part of the cranial nerves as well, like corneal, conjunctival jaw, and they are normal. So again, you are saying this is UMN is normal. We are talking about the LMN. Plantar is equivocal. Can you go down a bit more down, please? And clearly says sensations are normal. So as we are going more further, we are talking about LMN, peripheral neuropathy, whatever is the cause. Only motor part involvement, sensations are normal. No cranial involvement, no higher functions or UMN involvement. Cerebellar examination is normal. There is nothing specific positive in that. Can you go again further, please? Cranial nerve, as he already said, they are normal. Fundus is essential, and always check the eye movements, etc., which is normal. Can you go further, please? Still further.
Next.
I think, okay, so if you go back slide, so there is one part which is missing is as part of CNS, back, so back, spine and gait. Of course, this child cannot walk. So I will still mention gait we could not examine because his power is less than 2 or 2. And always because you have something to do with the spinal cord or nerves element, always, even if it's UMN, back and spine examination is very important. You may have some, say, gibbous and some tuberculous things happening and compressing your cord, or some trauma, or you may even transverse myelitis, you can have a line of demarcation at the back. So all those things are possible. Some injury, I don't know. So say back and spine examination was normal, say in this patient. And of course, I could not examine gait because of child's power. It could not permit me. So now if we summarize your CNS examination, so anatomy wise, this is, yes, sir. Yes, Kalma ma'am.
Actually, I wanted to ask him why he has written haphazard way, not in the sequential order. Cranial nerves should not be the last one.
Yes, please, ma'am. Take further, please, madam.
No, you just continue. I wanted to ask him why he has kept the cranial nerve examination at the end.
I think a very important point, and all the students, the exam point of view. These always the chronology should be in that any system. Don't try to jump or make the shortcut. There is no shortcut. I always tell my students that even 2 o'clock midnight, if you go for examination, the CNS examination point should be higher functions, cranial nerves, motor system 5 point, tone, power, nutrition, coordination, involuntary movements. Sensory system again central, then again the superficial and deep. We'll have to go for even more details of the signs of meningeal irritation, 3 signs, cerebellar signs, skull, spine, gait. That has to be there. Suppose everything gait is exactly what Nitish mentioned. You can say that I could not examine the gait due to this reason. Particularly suppose if you could not do something, but that point you cannot omit, and not in the way in which even you wish. That the reason is, that with specific ideas they have arranged this order or sequence. So best ways to follow it. I think very important, madam. In exam point of view, I thought that let me re-emphasize so that in the exam they will not do this mistake. Thank you very much.
During examination, you can do haphazard way, whatever your choice. But during presentation and writing, you should be systematic. Dr. Nitish, continue.
Yes, ma'am. So basically, it's so always follow the protocol. So if you miss something, and as sir said, if you're not done something, explain why not done. So examiner knows you were knowing the details, information, but it was not possible.
Yeah.
Or you attempted. So we are talking about whether. Sorry, Bhargav.
There is no any specific reason, sir.
That's fine. No. This is learning. This is learning for all of us. Even I would say this is not the right time to say, but still, we sitting here, we are learning a lot from Baldev sir. Like he was our teacher when I was student, so that was the era. But still, I'm learning a lot whenever I think like this or any case presentation, because basics should be there, and sometimes in routine practice we forget these things. So,
Bhargav, on the contrary, because I thought little bit you are disturbed, the mistakes are always possible. And and that's why I say that try to speak on the screen. And that, always I tell my co-examiners that what we are discussing after 35, 40 years of this working, and they are discussing after 3 years of working. So after 3 years of working, to speak in this way is definitely, I would say, highly appreciable. And even let me mention here my own mistake. In LG hospital in the round, I said very classically it was the thymic shadow. I took some 30 minutes for the discussion. And after a few days, that shadow disappeared. That was pneumonia. That was segmental pneumonia. But it happens so. And I think that's a bit of marriage. But I will say still, your way of discussion was not wrong. So it can happen, no problem. And on the contrary, if we discuss multiple times if you speak, I'm sure that in the exam, your performance is going to be the better. So it's an exercise, good exercise. I'm sure. I think now whatever the investigation, should we go for that so that we can have some time for the discussion, because now we have about 10-15 minutes. Dr. Nitish, should we go?
Yes, please, sir.
Okay. Okay, we can go further. Whatever PPT you have prepared.
Ultimately, my patient's diagnosis based on his history and examination.
Sorry to interrupt you. So here, even after examination, you should have a summary of your history and examination, important positive findings, and then you can do the diagnosis. So you carry on with the diagnosis, but that's something you should always do.
In the future, keep in mind, yes.
It is an acute onset flaccid quadriplegia with bulbar palsy without any sensory involvement and autonomic impairment. It is most probably Guillain-Barré syndrome.
It is with or without?
Bulbar palsy was not there in your examination.
So I think you should
it was in a course of hospital.
Okay.
Course and hospital.
Yeah. Okay. Further, anything else, or it is last slide? Bhargav?
Sir, my points in favor of GBS are it is a symmetrical and rapid progression, and there is no history of fever, and the patient is a fully immunized child till 5 years, and NCV suggestive of Aman, and on examination CSF has no any pleocytosis. All this favor my patient towards Guillain-Barré syndrome.
Okay. I think then we'll take the points in the discussion. You can finish your presentation.
This is last.
Okay, can you stop sharing now? Because now probably we don't have the further PPT. You can stop sharing. I think Bhargav said that there is no fever. But suppose fever is there only with this presentation.
Yes, sir.
Then what will be your thought process? Presentation is like this only, but the child is in fever and persistent, significant fever.
We'll try to look out into any infective etiology, and we'll try to go for examination whether there is an involvement of any presentation of any signs like meningitis.
How many examination findings are same?
Okay. But with fever.
But the fever is disturbing. Then what will be your thought process? And significant fever. Which is not convincing, as Bhargav said, for GBS, because it is not the common story. But somehow in this patient, which I got it, significant persistent fever with this type of picture. Then what will be your thought process? It's not malaria. Let me, because before you go further, no any other disease. It is due to the basic CNS problem.
Central trigger hypothermia.
What you will do? Ask Nitin, I think. Nitish must be have come across such problem. Please suppose in these other patient fever is there, can we give some other differentials can keep in mind, please?
Sure, sir. But first and foremost, even with the autonomic dysfunction, you can have temperature. Because that's very common. Of course, this patient, they said it was not there. Of course, it depends on the stage of disease. Even this child may have problem with the urinary retention, UTI as part of the GBS, or aspiration, pneumonia, chest infection, and fever from that. So these are all part of the GBS as a system involvement. It can be there.
So I think one point was Nitish pointed out. Suppose on the presentation, child was having pure classical picture of GBS, no fever. Later on, when the patient developed the problem, it is ICU problem. When you have kept the patient treated in this way. And that can be due to the nosocomial, some retention, if you have done the catheterization, pneumonia, ventilation, something like that. But again, if I come back, that it was not due to the ICU problem. And the point is, even Nitish has made, when the autonomous nervous system involvement is there. And the point is, probably, I think they will agree with me or will take their opinion, that prognosis this is the marker for the prognosis. Can you take, madam, that what importance can be there or some markers for the prognosis for GPS regarding the progress of the disease, regarding some of the manifestations of autonomous system? There are some, I know as a clinician, if you are aware, we can talk to the parents, whatever we have predicted. So, madam, can you take this point, please?
Yes. The first thing during examination point, you must know, whenever you're examining the child, you must examine the upper limbs. And if you know the shoulder, the deltoid muscles is involved. So what is the nerve supplied to deltoid muscles? Which nerve?
Shrugging of shoulder is lost.
You must know the sir.
Madam is asking. Yeah, madam is asking the nerve supply, the first MBBS.
Actually, the nerve supply, that supplies to the diaphragm. What is the nerve supply of diaphragm?
C4, C5.
345.
Pranic
So
nerve.
always keep, if the child cannot shrug his shoulder and cannot do the deltoid movements, he always impending to the involvement of diaphragm. So very carefully, please. First point for assessment. Second, as already discussed, of the respiratory. The progression, rapid progression. How long it will continue to progress? What is the duration of usual progression?
In 4 weeks.
Yes.
After 4 weeks, it will attain a plateau.
Yeah, and then it will improve or static, whatever it is. But up to 4 weeks
I think,
can be.
Madam, sorry to interrupt you. For the sake of our learning and the student, can you give the classical story of the GPS? That what is the progress, then what is the static, and what is the recovery? Then I think the deviation we can remember, please.
Anyone? Oh, so it is.
I think first any student, then madam will guide us. What is the classical, I will say, story of the GPS? That means how it presents. Then whether is there any time of the static? And then what is the stage of the recovery? Then if you remember that this should be the expected classically, and then it deviates, then it will give you the idea that this is something unusual. So that, as a clinician, we'll have to know the things. Any idea, Avni? You have? Only use your mic properly.
Hello.
Can't hear.
Yeah. Your mic. Microphone. I think you can hold your microphone to your mouth. Yes.
In front of mouth.
Sir, starting from the history of any preceding illness till the presentation of the symptoms, which could be acute as well as the most probably within maximum by 3 months, and then the presentation of the symptoms, progress of the symptoms within 2 to 4 weeks, 2 weeks, and then plateau phase for about plateau phase, and then there will be recovery phase, more probably 2 to 3 months, in which we will be providing physiotherapy and all.
Madam, you can make it, I will say,
Yeah.
fine tuning.
So so we are talking about the prognostic factors. Huh? So rapid onset and during the course of the disease, rapid onset maximum deficit in the very beginning is a bad prognosis. So if you have a quadriparity, totally the power is 0 and all, that has a bad prognosis. Rapid onset involvement of the respiratory muscles needed intubation is a very bad prognosis.
Yeah.
And of
Bhargav,
course,
you said that,
bilateral
you said,
cranial upwards.
yeah, Bhargav, you said that CSF was done. When it was done?
Is it necessary?
After 1 week for reporting purpose. Actually, we have diagnosed it with NCV, but for reporting purpose, we have to do CSF.
I think before that, Madam asked the question, is it necessary? Avni,
Is
what
it
is your
necessary for
idea?
diagnosis?
Not at all necessary at initial stage because we cannot diagnose it through CSF. It will be delayed albuminocytological association.
What will be the finding in your CSF?
Suppose somebody has done it at the
In the
right
first
time.
week.
Madam wants to know, suppose somebody has done at the right time, then what findings you will get it?
We will see albuminocytological dissociation. That is, proteins will be elevated, but CSF cells will be less than 10 to 20. If it is greater than 50, if it is cells count is greater than 50, it will be pleocytosis. It will go against contradicting to our GBS.
Yes, very good. Very good.
Only why it happens so that the
what are
protein,
the other
protein is increasing, cells are not increasing. Why it happens so in GPS?
Sir, it is not an sir, it is not an infective.
Then how the protein is increasing?
Maybe sir, alteration of any blood-brain barrier.
Brain is not affected.
She's giving explanation, filtration.
Again, these questions when the good performance of the student is there.
So what happens actually? What is the pathology? Can you tell me? What is the
Immune mediated, autoimmune mediated, antibodies will be present. So all
against what? Which structure? Against which structure?
Yeah, structure.
Which anatomical structure of the part of the system?
Axon or
myelin.
Peripheral nerve. Peripheral nerve.
It's a myelin.
Motor.
Myelin. It's a demyelination. That means myelin is affected.
So what are the other conditions where you get this aluminocytological dissociation? Can you hear me?
Yes, madam. Okay. Yes.
So what are the other conditions? GB is not the single one.
Partially treated aseptic meningitis.
So that answer is also wrong. This is also wrong. Because
I think in the lighter mood I talk, Bhargav, the way in which you are responding, the exam, either you answer properly or confuse the examiner. If you confuse the examiner, then also probably he will get that I'm not sure and probably what you are speaking may be right. You may get some benefit, but suppose the examiner is short, then it creates a problem, right? So I think don't try to guess every time. Anyway, madam, this is in lighter mood, but I think it's very important.
Yes.
So what are the other conditions? Very important.
Yes, anyone? Any other PGTs? Any other students? Can anyone answer? So it's a diphtheritic polyneuropathy, Leydig-encephalopathy, and Fryns syndrome. What is Fryns syndrome? What is Fryns syndrome? It's a syndrome, means the conglomeration of 3-4 symptoms. There will be a spinal block, there will be xanthochromia, and there will be aluminocytological dissociation. So these are the conditions we will get the aluminocytological dissociation, not only the GBS. The next question is how long it will persist. Suppose patient came after 3 months. Anyone? So I think now Dr. Nitish will answer rightly.
Ma'am. No, so ma'am's question is again, when you should do LP, when it's maximally abnormal and when it gets normalized. I think that's basically your pathological process we're talking about. So you should do within first week, ideally as soon as possible, but within first week. And by a second week, it will get normalized. So you will not see albinocytodissociation. So that you should know. So any other immune process will also show your albinocytodissociation, like NMO or anything.
I think next, some of these patients may start with the backache. That may be the first symptom. Probably weakness may not be during that time. And that is confusing to them. Why there is backache?
Yes,
Why
sir,
there is the pain is there? Avani.
Yeah, sir is asked very nice question.
And it is very important for the clinician to tackle because it's a complaint of the patient. Many a times when that pain persists after the treatment also. Then what will you do? First, you should know the reason. Bhargav? In another way, what is the another way of the name of the GPS? How do you call it another way?
Lawn.
Anatomical involvement point of view I'm talking. Do you call it, suppose if I want to remind you, any idea, or should I give some clue? It is also called as a radicular neuropathy. Is it right?
Yes, sir.
So how the name is derived?
AIDP.
Radicals are
AIDP. What is the full form of AIDP?
Yeah.
Acute inflammatory demyelinating polyneuropathy.
So what is the site of pain now? Which structure is responsible for the pain?
Nerves.
Radicular part of peripheral nerve.
What is the radical? What you know? Anatomically.
In the spine. After nerve root level, in the spine, in the spinal cord, in the vertical column,
it's a root pain. Right, it's a root pain. Now, why this pain persists? And even, is there any specific treatment? Suppose if you are given the immunoglobulin or suppose plasmapheresis, whatever you have done, sometimes patient responds, even stables and gradually showing recovery, but the pain is disturbing. Then what you should do? In another way, if I ask I think before that, if I ask the question, Bhargav, is there any role of the steroids in management of GPS? I think we know the immunoglobulin is good, plasmapheresis, but is there any, because already you have done. But suppose patient is not affording, somebody says that give the steroids. Is it going to work?
No any scientific evidence suggests this.
I think let us learn from expert that regarding the steroid, because it's very common query and question to the practitioners, and sometimes if they are not aware, probably we are not managing properly. That thing should not happen. So clear message should go. Nitish, can you get it? What is the role of steroids in GPS?
Sure, sir. So taking one step back, what sir has said, of course, diagnosis is your NCV, CSF means supportive for ruling out things, but very important exemption means investigation finding is your MRI spine with contrast in early stage. Even on first or second day of presentation, NCV may be equivocal or may not be positive, but your ventral cord or anterior cells in the lower spinal cord, lumbar region, they will be illuminated with a contrast, and that's clinical radicular neuropathy. So that's how you can also diagnose, and that's the reason you have the radicular pain. Now coming to the question, yes, if it's slowly progressing, like what ma'am said, AIDP, and just it's slowly progressing disease, steroids does help. It does help. It reduces inflammation. And anyway, this is autoimmune disease. So your body, how body responds, it's also important. But those patients, the disease process slows down, pain goes away, and body gradually takes over. So those patients may not need any IVIG. But that's not the standard care. I agree with you. Especially on day 1, day 2, you don't know how the child is progressing. Like your child, it is a man presentation. It axonal, your myelin is totally gone. In one thing, your myelin sheath is inflamed, but intact. That's your AIDP. But if your myelin is totally gone, that's axonal, axons are totally gone, Oman variety, where your progression is very rapid and you have bad prognosis or outcome. So those patients never try steroids. But those patients with the slow AIDP initially, you can try steroids, methylprednisolone.
Nasal AIDP on, in CIDP can.
Yes. Okay. And gradually as time permits. Yes, ma'am.
I think now gradually we have to keep in mind the timing also.
Sure, sir.
Yeah.
Bhargav, one more point, I think, exercise in this page, I hope that you must have done. What is important for us in such patients? One, I will say, one important, I will say, step by the treating person, health authority point of view. In other way, if I ask you, have you reported this patient to this corporation?
Sir. We will do IDSP surveillance. This patient is having acute flaccid palsy.
Avni, is it right? Somebody says the neurologist. It is a GPS. I know the GPS. Why I should inform
But
this?
still, sir, any flaccid paralysis should be reported under AFP for AFP surveillance.
Up to what age?
4 weeks.
Age of the patient. Age of the patient.
15 years of age.
15
And
years,
if whenever we are suspecting polio, no any age limit.
But if somebody says that I have reported so many patients, nothing has come positive. Why unnecessary we should go?
It is positive in 1 lakh. It is around, it should be around, if it is our AFP.
The point is, should I go?
Sir,
Or what is this, I would say, rationality? Just because somebody said some government we have to do? Or is there any some science? You know, so many points in the government that just some they say and they will have to do. So I think, is it also like that?
Since India is surrounded by Pakistan, there are few cases in Pakistan and Afghanistan, and they are our neighboring countries. So we'll have to keep follow up for that. So and
no, that is for the polio. Sir is asking, yes, it's non-polio also, like now revised guideline, even hypokalemic paralysis to be peripheral neuritis, hypokalemic paralysis, even the facial palsy to be reported. Why so? What is the importance of science behind this?
What is the rationality? What is the idea? That's, you know, what I want to convey.
Sensitivity.
Not even a single case. It doesn't mean since there are no cases since this much time, it doesn't mean there won't be any cases. So to exclude out each and every cases from minimal level, from tertiary care hospital to any some small CHC or sub district, if any case is reported, the chances of missing out any cases will be lessened.
Good. I think, you know, we have reached to this juncture of polio eradication that we cannot afford. We cannot afford even to miss a single case out of your legs together. It's on the contrary, now it is mandatory.
To increase the sensitivity of the surveillance.
Yeah, sensitivity of the surveillance.
Of the surveillance. You know the surveillance, what is the...
Yeah, absolutely what Madam said. And for your information, even surveillance of the AFPO's government of India, it has been appreciated by the WHO. That we are doing a very good job from this point of view. And I think that we should continue. And as I will say, pediatrician of this country or neurologist of this country, we should be fully aware. And we'll have to do. Therefore, if the exam probably somebody may trace the importance of this AFP reporting, and that we should know. I think maybe they were the exam in the theory also the full question. AFP surveillance. So please keep in mind. I think anything else, madam, because we have overshooted the time. Now we'll have to wind up the things.
Yes,
so,
sir.
yes, Dr. Mehul.
Nice.
Sir, I want to have one query because IAP, as we have dignitaries, yourself, Kalpana madam, Yogesh sir, Nehal madam, that there is one portal called ID Serve started by IAP. So I want to know the status, whether it is running or not, and can we report along with IDSP program of government on the ID Serve? We have any database of such kind of cases of GBS or all those things from IAP side?
I think Yogesh may be knowing the present status, but if I inform the past, probably it was there, it present also. It is there in the ID. Particularly, I think Dr. Naveen Thakkar and his team, they initiated. It's going on, and it is very, very important. We should. Somehow people are not doing regularly in spite of these reminders, sensitizations, but we should do. Any recent information?
No, sir, I don't have any idea about the IP. I don't have.
Madam, Prajapati sir, it is there in the, but people are not using the ID survey right. Most of the it is in the dormant state, but we can report and we can generate the data.
Okay, anything or we land over here? First, I think Bhargav, best compliments from, I'm sure, not only from me, but all the teachers. You have done a very good job.
Yes, yes.
I'm sure that you must have worked very hard. Of course, under the guidance of Dr. Mehul and the other faculties from the college. And I will appreciate even all the students who participate in the discussion. Dr. Avni, Tushar, even Esha, and good, I will say. I will say such students should not get, I will say, loss because they didn't get the opportunity for the sensitization or proper learning. You should be probably stretch out your teachers for learning. Probably next time Dr. Mehul may not even call me, but this is very important. I'm always encouraging the student. I'm always telling my first year resident to my junior, I would say faculties, assistant professor also, that sir, if you don't teach me the 5 things new, I will not allow you to go at 5 o'clock. So you'll have to teach something 5 points daily. So I think you can also ask. The reason is, I'm sure you have the very good potentiality, all the students. So, and please participate in the such type of the exercises, not only I will say from me or DIP or any teacher, whoever is doing, and participate, and that's the best way of learning. So I think don't miss it at any place. And I invite all the students that at any time you can. I'm sure that because now we want to contribute something in your development. And this is the really opportunity for us also to do something for the students. And all the students really did a very good job. Thank you very much. And of course, both the experts, Dr. Kalpana Datta and Dr. Nitish, our own person, you know that, and therefore even I'm encouraging the students also, that being general pediatrician, I may not be, or any faculty, may not be probably aware of all the aspects of your developments that can be contributed by the experts in the field, and ultimately by the contribution of multiple faculties, the whole exercise becomes very fruitful. So thank you very much, both the experts, and of course our Yogesh Bhai, President Secretary of our Gujarat State Branch, Dr. Rakesh Desai and Kriti Sisodia, and even the Nehal. Actually, she is the key person in the whole show. She is managing the mentor, the presenter, the experts, and then I'm sure that somebody should be there to prepare this platform. And she's the very good, I would say, very important person, backbone behind the whole exercise. So thank you very much to all of you. And I think now it is over to Dr. Nehal. Yes,
Thank
madam.
you very much, sir.
I wanted to say a few words.
Yes, madam, please.
Yes, sir. Without your guidance and your presence, it won't be possible to conduct such a nice academic session. You are always there, and every week I see, and really hats up to you. You are such a sincere. I mean, the sincere from this point of view, in the more sincere than the students also. So
Sure,
we are really inspired by you. Really inspired.
Sir, so inspiration as well as we learn from you, sir.
Yes, sir. We learn lots of things from you. And I also thanks for inviting me as an expert and giving me the opportunity to learning and teaching also both. Thank you all.
Nihal, I hope that you
And
are
happy
there, Dr.
Durga
Nihal.
Puja.
Yes, sir. Actually, I'm driving. That's why my video is not on.
Okay, you can take it further, please. It is winding up, please.
Yeah, thank you very much, both the experts, Nitish Bhai and Madam. And we are so happy to have you. We try to prepare our students, and even we can take other students at your institute also for e-Gurukul. As sir said, I'm collecting the characters, but whole show is managed by sir. So I'm very much thankful to Baldev Prajapati sir, and Yogesh sir is always there to help me for choosing the mentors, as he is there having all India representations. So thank you very much, everybody. Yeah, and thank you Bhargav and all other students. Thank you so much.
Thank you. Bye-bye.
Thank you,
Thank
mentor
you.
also, Dr. Karunan.
Again, I think next
Yes.
Saturday we'll meet with some new case.
Absolutely. Dr. Mehul, well done as well. And thank you very much, everyone.
Yes,
Thank you.
Mehul bhai, thank you so much, sparing your students, so many students at a one time.
Yeah.
Thank you. બધું આગળનો હિસાબ સર પર થઈ ગયો.
And happy Durga Puja to you all.
Yes, thank you, ma'am, and happy Durga Puja to you as well, madam.
Yes.
Prajapati sir.
Yeah.
After the every session, we are getting the feedback from the experts. We learn something more 5 points today after today's teaching. So with the show of the Dr. Baldev Prajapati sir, not Yogesh or not Dr. Nehal or anyone, but you are managing, sir, and you are managing the twice or thrice a week PG clinic. So it is excellent academic work conducted by you, sir, and we are proud of you. You are always with us. Thank you, sir. And Dr. Kalpana madam and Dr. Mehul bhai, Dr. Nitesh bhai and Dr. Nihal madam. Thank you.